Hi, everyone. Welcome back to part two of Health Equity, Disparities, and Reform. Again, my name is Dr. Dennis Daniels. I use he, him pronouns, and I'm delighted to have you back as we continue discussion and presentation of health equity, identifying those barriers to health equity, and use this opportunity to provide examples of reform efforts that have challenged those inequities. To give a quick overview of what we're going to talk about today, we're going to start off, as I promised at the end of part one, discussing frameworks that help us to better understand health equity by discussing examples of a framework that can be used to identify variations of vulnerabilities across populations or varying from individual to individual, as well as a framework that helps us to organize factors that contribute to varying levels of health outcomes in society. And then we're going to close off by discussing examples of how health inequity have been challenged over the years. I'm just looking at various levels of reform efforts. And again, health equity, when I'm referring to health equity, this is the fair and just opportunity for everyone to be as healthy as possible in society. This can only be done through adequate power and privilege in society when it comes to acquiring resources or being able to utilize services that can help us to accomplish this. There are, when we look at varying levels of health outcomes in our society, different barriers that deprive us of accomplishing this. And these barriers or these inequities can lead to what we call health disparities, the preventable and inequitable differences in health that we see when we look across populations. And so examples of barriers to health equity are food insecurity, looking at the lack of nutritious and available food among different communities in our society can show a level of inequity and present themselves when we look at the impact as it relates to different health outcomes. As I mentioned in part one, East Buffalo is considered by many in discourse to be a part of the city where it's been difficult for many residents to access sources of nutritious and affordable food. When we look nationally, over 42 million Americans experience food insecurity, and 13 million of them potentially are children. And so food insecurity is certainly a barrier to health equity. Also, sanitation in one's physical environment, whether it be looking at water, the quality of water that they have to drink, air pollution, certainly pollution and sanitation matters very much contribute to inequities that we see in our society. Unsafe and unstable housing, lack of education, inaccessibility to healthcare. We spoke in great detail about that in part one. And then looking at the presence of social stigma and discrimination and how this can have an impact on underuse of healthcare services that are very vital to really setting one up to thrive. So how can conceptual frameworks help us understand health equity? We know conceptual frameworks help us to organize factors that contribute to varying levels of health outcomes, either by organizing those factors according to population level, or by organizing factors according to varying convergence levels between individuals and communities. The vulnerability framework, introduced in 2010 by Shai and Stevens, introduces this concept of vulnerability, which is the likelihood of experiencing, in this context, poor health and illness due to the manifestation of physical, mental, and social dimensions of wellness. This framework posits that poor health in one dimension of one's life. So looking at the multiple dimensions of wellness, physical, mental, social, emotional, environmental. Some models have more dimensions, but essentially those five are critical to one's well-being. Shai and Stevens argue that poor health in one dimension is likely to lead to poor health in other dimensions. So this is, a comprehensive model that helps us to look at how various levels of vulnerability can collide with one another to yield varying outcomes among populations or among individuals, depending on how the framework is used. And so, again, this model posits that vulnerability is determined by a collision of either predisposing factors, such as one's background characteristics, whether it be race, culture, other social factors, enabling factors, such as one's healthcare coverage status, and both individual and ecological needs, such as medication needs, one's disability status, one's access to nutritious food or clean drinking water. These factors collide with one another and can have an impact in one's access to care, one's susceptibility to illness, and one's likelihood of recovering from illness. And so this vulnerability framework has us understand that the more vulnerability traits a person has, the worse their access to care and their overall health status will be. And so not a perfect model, but certainly one that's utilized widely by a number of health agencies. There was a study done a few years ago in Chicago to assess the presence of vulnerability traits among residents of an underprivileged community in the South Side of Chicago. And this helped to provide a basis for interventions to provide more nutritious food sources, community gardens, for example. A number of farmers market initiatives were launched in that part of the city to help to offset a number of concerns as related to food insecurity in addition to other vulnerability factors. Another framework that is used widely in public health and among many healthcare professionals to organize factors that contribute to health outcomes is the social ecological model. And the social ecological model, also known as the socio-ecological model, helps us to better understand how we can challenge inequity on various levels of interaction. And so the framework posits that there are several spheres of influence over human behavior and lifestyle. And each level provides a means of influence over health. And keep in mind that these levels or these spheres of influence interact with one another. And so breaking down the levels from the most direct is individual. And so this is the knowledge, attitudes, beliefs that one have as it relates to their everyday experience. When you're interacting with other people, this leads us to the interpersonal dimension where, we have relationships with individuals, families, friends, social networks. And then when we have clusters of relationships interacting with one another, we're looking at the organization level, where organizations, organized efforts usually are implemented. Social institutions may be established. And then from there, the community level, where we have relationships between organizations. And then the most broad level, according to the model, is the societal level or public policy level, depending on which version of the framework you use, which is generally where laws are established and we look at affairs on a population level. And so taking this framework to organize and structure factors and efforts that can challenge health inequities, when we look at the individual level, again, we're looking at personal attitudes, beliefs, and behaviors. So interventions, for example, that target behavior change. For example, having one to increase their frequency of wellness visits or attend screenings to better track one's health and wellness or one's susceptibility to a chronic condition or some kind of illness can greatly have a positive impact on not only one's individual wellness, but when we look at the impact over populations or over a period of time, this can lead to changes, trends across different vulnerable groups or different vulnerable communities. On the interpersonal level, interventions that focus on developing social support or developing strengthened relationships with either community organizations, community wellness centers, or even directly with healthcare providers at an institution, clinic, or facility can have a positive impact on not just the practice and better inform the practice of those providers, but of course impact the experience and the behaviors among individuals on an interpersonal level. Group counseling, for example, to help with trauma reform efforts has been shown by research to be highly impactful, not just because it builds a relationship between the therapist or the provider and the patient, but it can also build social support between individuals who are seeking counseling, who are seeking help and support. And so this builds an interpersonal level reform effort. Looking at the community level, looking at, for example, community level organizations that impact health, community wellness centers that provide services and resources to underprivileged communities who may have accessibility issues, may have accessibility barriers, community gardens that can be used, as I mentioned earlier, to challenge food insecurity among areas that have been described as food deserts or deprived of nutritious sources of food, can have a community level impact on this particular issue. When we look at institutional levels, we look at what agencies and health departments can do to provide change. For example, setting protocols for employees and county residents as it relates to their practice or their standards in engagement with patients, perhaps an assurance of diversity and quality care among underrepresented demographic groups, in addition to majority population patients, can provide change. And then when we get to the societal level or the public policy level, we're looking at ways that we can establish laws or regulate institutions, different spheres in our society that have power and influence to better ensure that equity is at the center of day-to-day affairs. And so, looking at a lack of diversity in the healthcare workforce, laws can be established, directives can be provided to agencies and institutions to better ensure that diversity is at the center of recruitment and retainment efforts, as well as cultural competency trainings and cultural responsiveness approach, patient-centered care approach as it relates to interactions with patients. So let's talk about how we've challenged health inequity. So first of all, when I'm talking about reform, generally speaking, what I'm describing are enhancements, revisions, and implementation measures of either policy, programs, research projects, or the implementation of services or the providing of services that can reduce inequities in health in our society. And really, this extends to the provision of funding for federal level, state level, and even local level equity programs, either by the federal or state governments, in some cases, nonprofit organizations on the local levels that can spread awareness through seminars, providing low-cost services to underprivileged populations who are at an economic disadvantage. Even more so lately, looking at the lower middle class who may not be eligible for public plans such as Medicaid, nor are they able to afford marketplace coverage plans that were provided under the Affordable Care Act. So starting off by looking at the federal level, what are some things that have been done nationally to impact institutions and organizations, and of course, individuals in our society? The American Academy of Family Physicians Foundation Center for Diversity and Health Equity recently launched the Everyone Project, which provides directives to medical professionals, to various professionals and organizations and nonprofit collectives to promote workforce diversity and challenge workforce diversity issues that can deprive or inhibit the strong rapport between underrepresented communities, marginalized communities, and providers. I mentioned earlier how discrimination and social stigma between marginalized communities and the healthcare profession has led to underuse of service. And diversity has been identified as a factor of focus that can potentially increase the use of service among marginalized groups and have been the target of discrimination many times from the healthcare industry. We talked about in part one, the Tuskegee syphilis study and how this has just left a bad taste in the mouths of many African Americans in our society. And something that is not forgotten and not failed to be referenced when discussing reasons why an underuse of service may occur, or why skepticism as it relates to new treatments to prevent illnesses such as the COVID-19 vaccine can take place. And so diversity, and when I say diversity, I'm not just talking about in terms of recruitment and retainment of different professionals, especially those who may be from those marginalized groups. And this certainly has been proven by research to have a positive impact on increasing the use of service among members of population groups that have been historically disenfranchised, but also looking at the agenda, the objectives that are prioritized by the outpatient facilities, clinics, hospitals, nonprofit organizations, health associations as well, how they can be more inclusive to the needs and the priorities of various underrepresented communities, so that it's not just a matter of serving those communities, but the community's needs and priorities are also prioritized as well by that entity. And so the Foundation Center for Diversity and Health Equity provided directives to medical professionals as well as resources to challenge workforce diversity issues that were noted by research. 64% of healthcare facilities we know are not properly staffed to address risk factors among underrepresented demographic groups. Over 80% of physicians don't have time, they've reported, to discuss social determinants of health with patients, despite the necessity of this presented in research. And so, this initiative, the Everyone Project, provides directives to these medical professionals and healthcare professionals to equip them with trainings and the means to facilitate discussions on how patient-centered care, culturally responsive patient-centered care that can be implemented, can be applied to practice. but also how to be more inclusive to the needs of those marginalized communities as it relates to what priorities and what agenda objectives are considered moving forward. Looking at the state level, we know that several states are, or rather have at this point, developed Medicaid equity to provide reform with how healthcare is financed and organized. This has the potential to improve population health among various underprivileged groups. For example, the Massachusetts Accountable Care Organization program emphasizes social determinants of health and the enhancement of behavioral health services. So, this challenges accessibility barriers. This initiative also includes partnerships with other behavioral health organizations that desire to provide comprehensive care management services to underprivileged communities as well. And so, the Massachusetts Accountable Care Organization program joins other efforts in other states that are very similar to target those accessibility barriers. Let's talk about the local level. When looking at what's going on right here in Buffalo, in addition to other cities in our region along the Great Lakes, something that comes to mind quickly when talking about sanitation related to water is the Water Equity Task Force. And this is an initiative that's been facilitated through the partnership of many environmental health and public health equity organizations across a number of cities between the East Coast, Western New York, and the Midwest, including Buffalo. And the aim of the Water Equity Task Force is to do just that, provide an assurance of equitable water management, as well as to ensure safe water quality and flood management. We know, many of us know from living in this region that floods are likely to happen during certain times of the year. And we don't want to wait, certainly, until situations call for a response to respond. And so, flood management efforts, as well as an assurance of safe water quality, is among the priorities of the Water Equity Task Force. And so, this includes the adoption of equitable water policies, utility practices, and community-based organization collaboration. That's extremely important. If you're going to certainly meet the needs of a community, whether it's an affluent community or a marginalized community, you have to be inclusive to the priorities that this community or those communities have. And so a collaborative effort, one where maybe there's an advisory board, such as the case with the Water Equity Task Force, where the priorities and the advised objectives are represented, are disseminated to members of the task force, or ways that you can engage the community in evaluation objectives, because these projects need to be assessed for effectiveness, to make sure that the outcomes are met, but also in terms of efficiency and in terms of reliability and how these measures are carried out through process evaluations. This needs to occur. And including the community in evaluation objectives is part of how this can be accomplished. And so this is just one of the many avenues of the Water Equity Network. Water Equity Task Force, of course, is a foundational avenue of this initiative. in ways to challenge water pollution related barriers to health equity. And this is, like I said, done on the local level. And really, this could be arguably regional because it consists of multiple cities. But Buffalo, New York is one of them. So, some key takeaways before we end and conclude today. Certain population groups face greater challenges than others, and this can yield to a greater risk of poor health. The vulnerability framework from Cheyenne Stevens helped to point out how a variety of traits and factors can collide to present a difference in outcomes among different groups, and the higher levels of vulnerability in an individual or within a community can lead to a higher susceptibility toward an illness or poor health, as well as a number of barriers that can deprive one of living a healthy life as possible. A fragmented history between historically disenfranchised communities and the healthcare system has led to generations of distrust and underuse of services. Factors like discrimination, income, location, coverage status, and many other social factors and political factors not only impact the likelihood of one contracting an illness, but can also have an impact on the likelihood of recovery from that illness and access to services that can help facilitate that. Policies, programs, and other directives, as we just saw during the remainder of this presentation, provide efforts to challenge these inequities in our society. And so, everything from the Everyone Project, challenging workforce diversity issues, and providing a greater assurance, of culturally responsive, patient-centered care among medical professionals, to the Water Equity Task Force that provides a greater assurance of safer water quality, flood management, and water management resources to various cities along the Great Lakes, including Buffalo. These are just some of many examples of how reform is executed to challenge inequities in health. And so I want to thank you for taking time to tune in to parts 1 and 2 of health equity, disparities, and reform. And I wish you all the best with the remainder of your semester.